Доброго вечора, українські радіаційні онкологи. Слава Україні! Дуже дякуємо, що ви приєдналися до Case Review with ASTRO Experts for Ukraine. Today we have a session on glioblastoma and we have two great speakers, Dr. Chen Jake Wang from US and Dr. Olha Silaieva from Ukraine. Dr. Wang is a board-certified radiation oncologist with a background in both research and clinical practice. He holds a PhD in bioengineering from University of California, Los Angeles, where he conducted basic science research before transitioning to medical training. He earned his MD at the University of Connecticut School of Medicine and completed his radiation oncology residency at UT Southwestern, gaining significant expertise in SRS and SBRT. Currently, Dr. Wang is a part of a team of Willis Knighton Health in Shreveport, Louisiana. He's specializing on CNS tumors, treating lung cancers, and also proton therapy. He also holds an adjunct appointment at Louisiana State University Health Shreveport School of Medicine, where he is actively involved in training medical students, residents, and fellows. Welcome, Dr. Wang, and thank you for teaching us today. I also learned that Dr. Wang is originally from Taiwan, and Taiwan really supports Ukrainian stride for freedom. Thank you so much for your support, Dr. Wang. And our second speaker is Dr. Olha Silaieva. She's one of the leaders in radiation oncology in Ukraine. She specializes in CNS tumors, neuro-oncology, and stereotactic radiosurgery. She's a chair of radiation oncology department in Oberich Clinic in Kyiv, and she's also a very active participant in various conferences in Ukraine and abroad. And we are very excited to have this session today. Dr. Wang, the podium is yours.
Thank you very much for the introduction. So let's see. Can you see the slides?
Yes.
Okay. So thanks for having me and for us to discuss about glioblastoma. So I am a radiation oncologist I'm currently in Willis Knighton Health in Shreveport, Louisiana. Most people doesn't know where Shreveport is, so I have a little map here. So we're right here at the northwest Louisiana, right at the border between Louisiana and Texas. So we have very nice people, we have good food, and so if you guys have a chance to visit, we'll always welcome you guys to come. So we are a site has both proton and photon capabilities, and we're in a community practice. So the cases I'm going to talk about today, some including protons, but I know proton may not be available for most for some places, but the underlying principles are still the same. So for the case review, and here we go, I guess. So for the first case, we will start with a 49-year-old man. He's previously healthy, no medical issues, and then had a first ever witness seizure. And on retrospect and looking back, he does have a couple episodes of that he froze and couldn't move, but he didn't lose consciousness about all these episodes. So because of the seizure, he was brought to the hospital, and then he had imaging. And on the imaging, you see that there's a mass, centrally necrotic mass with a peripheral heterogeneous enhancing lesion in the right parietal region. So he was evaluated by the neurosurgeon and taken to surgery and had a good resection and gross total resection per op report. And on the post-op imaging also looked pretty good. Pathology unfortunately showed glioblastoma, IDH wild type, 1p19q was intact, and MGMT promoter was methylated. Post-operatively, the patient is doing pretty good. He's back to his baseline. No obvious neural deficits. He's on seizure medication, no further seizure, and the steroid was able to be tapered off. So before going into the questions, let's talk a little bit about initial management. Most often, glioblastoma common symptoms, they presented with headache, seizure, some cognitive changes, neurological deficits from the mass effect. Some of them may even have DVT or PE presentation. And for these symptoms, we generally start with the corticosteroids, have seizure medication on board, and then provide pain medication as needed. And workout-wise, the patient definitely need a good MRI with or without contrast. I often ask for a body CT scan to make sure there's no concurrent primary disease, and then get some basic labs, just to know the basic organ functions, and also helping the surgeon to assess the resectability. And of course, the patient need to request neurosurgery consult to get a surgical evaluation. Classification-wise, glioblastoma classification has evolved over the years. Initially, it was based on histology, characteristics involving the increasing cellular atypia, high mitotic figures, endovascular proliferation, and increasing necrosis. In the most recent two WHO classification actually integrated the molecular subtypes. The most recent ones that you can be both IDH wild type or IDH mutant, but for the IDH wild type, as long as it has these couple of molecular characteristics, like EGFR amplification, TRT promoter mutations, or the chromosome 7 plus chromosome 10 loss, these couple characteristics can be characterized as molecular glioblastomas. If it's a IDH mutant and 1p19q intact, and then we can check for the CDKN2A or N2B homozygous deletion that can characterize as the WHO grade 4, treating as a glioblastoma. Even though the MGMT promoter methylation status is not characteristic for the glioblastoma, it is a prognostic and predictive factor for high-grade glioma, so we generally should get it to have a better assessment. For the prognosis-wise, before the molecular era, we based on the clinical characteristics. From the RTOG recursor participant analysis shows that the age, performance status, degrees of resection, and whether presented with neurologic deficits can predict the patient's outcome based on different classes. From the EORTC, the STOOP study, they generate a nomogram. They're looking at the age, performance status, and the surgery are all part of the nomogram. Instead of the neurological deficit, they use the mini-mental status score to assess the neurological conditions, and they can predict the outcomes. In the more modern era with the molecular information, the MGMT status as well as location of tumor become important. And from the RTOG 0525 and 0825, those two studies, both forming the model and validated, actually shows that there is difference between male and female. And for the generally female do a little bit better than the male. And for the male, actually, the use of corticosteroid is as an unfavorable characteristic for predicting the survival and progression-free survival outcome. So for the first step of glioblastoma, generally need to request for surgery. And the goal of surgery is maximum safe resection. And complete resection is the goal. And we know that complete resection can generally associate with a better outcome. And there's multiple techniques trying to improve the to improve the complete resection, including ultrasound, MRI, and the 5-ALA tracers can all facilitate better resection, and that can correlate it to better outcomes. And I just list a couple of the surgical studies, and you can definitely discuss with your surgical colleagues. The role of supramaximum resection is kind of debatable, but it's quite interesting. Supramaximum resection meaning that not only resecting the enhancing area, but also resect the abnormal flare. And it has been debated whether this benefits for the patient or not. But more recently, a meta-analysis and the analysis from the Reno group as looking at the reclassification of different categories, they show that the supramaximum resection, that is resecting all the enhancing lesion and has minimum flare abnormalities, placed as a class 1, complete resection of the enhancement versus subtotal resections. And they show that the more resection you get, including supramaximum resection, actually the survival is better. So, I think it's still an area under investigation, but there are some data suggesting that when the patient can tolerate a little bit more resection, the outcome may further improve. So back to the case one for the questions. So just to summarize, this is a 49-year-old man with good performance status, and IDH wild type, MGMT promoter methylated, complete resection, but no obvious deficits, recovered well. So what would be your recommended adjuvant treatment? So I guess can we see how many people responded or no?
Do you see a pop-up on top? It shows
Actually,
us
I don't. I only see.
66%.
Okay.
Okay, I can tell you.
Okay. Yeah.
Mhm. So we have 83% responding, waiting for a few more to 85% at least. One more answer. Okay, I'm gonna end the poll. Share results. Do you see the results?
Yes, I see the
Okay, great.
results. So it seems like more than half would choose the full course radiation, concurrent chemo, adjuvant chemo, and then tumor treating field. A good 30-40% will do radiation with concurrent chemotherapy, and some would only do radiation alone, right? So,
Mhm.
okay. So yeah, so that's understandable. That sometimes depends on your the resources at different facilities. But that's both the first two are quite reasonable. And yeah, all right. So so this so radiation for glioblastoma has been demonstrated clearly have benefit for newly diagnosed glioblastoma, right? So in the multiple randomized study in the past showing that radiation can improve survival after resection. And even for older patients, there in the early 2000s, the French studies for randomized study for patients older than 70 years old, and then they randomized between supportive care versus radiation. In the modern radiation techniques, they show that radiation improved the survival as well as disease progression comparing to just the supportive care. And that's showed it in the New England Journal of Medicine. And radiation technology techniques also evolved over the years. And from the originally whole brain radiation to now the partial brain radiation, from the older 3D conformal radiation, now most people can do IMRT or VMAT treatments. And that can reduce the side effects and toxicities. And we also show that multiple studies shows that dose escalation, at least to 60 grades, seems to have some benefits. And these are all older studies from the UK, and as well as the brain tumor study group shows that there's survival benefit with increasing dose up to 60 grade. However, when dose escalated beyond 60 grade, hasn't really been demonstrated benefit including trying to use the proton, including trying to do the radiosurgery boost or the other additional radiation boost that hasn't really shown beyond additional survival benefits. For this study, everyone should know this. This is the URTC NCIC STOOP study, and they have a glioblastoma patients, good performance status, randomized between radiation with or without concurrent and adjuvant temozolomide. And they show that adding temozolomide improves survival and with slightly increased toxicities. And they also show that methylated MGMT promoter status was prognostic as well as a strong predictor for benefit from temozolomide. So that becoming the kind of standard, at least one of the standard for treating glioblastoma. More recently, German has a study looking at the glioblastoma with methylated MGMT promoter tumors. And these patients also have good performance status, have a methylated MGMT promoter status, and they randomized between lomustine with temozolomide versus temozolomide alone with the radiation. And they show that all of these patients got 60 gray in 30 fractions. And then they show that actually the two chemo regimen, the lomustine with temozolomide, actually improved median survival from 31 months to 48 months. So seems like there's the potential, they're suggesting that MGMT methylated tumors can do better with actually escalating the chemotherapy regimen. So for the radiation planning wise, I generally see the patient about 2 to 3 weeks after the surgery, and we plan the radiation simulation about 4 weeks after the surgery. And the patient will be laying on table supine with a thermoplastic mask. And I always need an MRI to plan the radiation. We fortunately have an MRI simulator in our department, so we can do the MRI at the same time. But at least you should get the MRI within 2 weeks from your simulation time. Generally, the cavity still evolves for about 2 weeks after surgery. So we try, if the patient had the MRI right after surgery, you still need to update the MRI at the simulation time. And then you should also determine whether the patient you treated with a 3D conformal radiation, IMRT, or proton radiation, depends on your facility setup. So then after simulation for this young patient, relatively young patient, what would be your initial treatment volume? I want to ask about the initial CTV volume. So the first is like the post-op bed plus the residual tumor plus the flare, everything expanding 2 centimeters. And then the second option is to post-op bed plus enhancement expand 1.5 centimeter. And the third option is the just enhancing tumor, but in the op bed, no expansion. And the fourth is just almost like a radiosurgery volume, just a residual tumor without expansion. And there may not be absolutely right or wrong answer. Just I want to see what is everyone's practice pattern.
Sounds good. So we have a 90% answering. I'm ending the poll and sharing results.
All right, that's pretty reasonable. A majority of people choose the first one or two, and that brought to typically this the first option is actually RTOG, like a contouring guideline, and the second option is the ERTC volume guideline. I put a reference here, and the ERTC guideline did update it last year. So the most updated guideline looking at just the enhancement without the flare, unless there's clearly tumor involvement with a non-enhancing tumor in this area. So they also able to reduce the margin from 2 centimeter to 1.5 centimeter. And they did talk about using special PET scans. They can consider that. But I think this is also an interesting area that may be evolving over the next couple of years. The PTV margin depends on your clinical setup, but with image guidance, typically 3 millimeters is pretty good. For the RDOG, generally we have or NRG, we generally have 2 dose levels. We have an initial volume with including the flare that expanded 2 centimeters, and that's to the 45 to 50 gray area. And then we come down to the cavity with the enhancement 2 centimeter to total of 60 gray. And they did kind of discuss about if the tumor is right there when the brainstem, you may need to kind of like carve it back a little bit. they do think that for the gross disease, you should still give the gross disease to at least 54 gray. And then for the optic nerve, they actually allow the tumor, if the tumor is involving or abutting the optic chiasm, optic apparatus, they do recommend treating the tumor up to 60 gray. Of course, that the rate of causing the vision issue is higher, but that is the tumor is directly touching the optic nerves. So for the planning wise, I generally want to have at least 95% of the tumor volume of PTV volume receive the 100% of the dose, and I want the minimum of the PTV receive at least 95% of the dose. I usually try to make sure that the plane is relatively homogeneous. I try to keep the maximum dose lower than 107% and try to keep the 105% less than 10% of the volume. And that's typically for a VMAT plan. For the proton plan, because we don't use the PTV planning, we use the CTV robustness optimization. So generally we need two or three fields and then do a 3.5% plus 3 millimeter set of error for the robustness planning. And for the constraint wise, this is from the EORTC on the left side, and on the right side, I put the NRG BN001 study. That's the constraints. The most important constraints are the brainstem and the optic structures. And generally, these can go up to 54 to 55 gray, and for unless it's specific conditions that need to go up to 60 gray. The pituitary gland, I try to keep as low as we can. The EORTC keep it max less than 50, but 50 will still have a lot of deficits, I would say. And the cochlea, of course, that we can save it if we can at least save one side, if cannot save both sides. So I understand that a lot of places may not have access to proton, but here I listed some of the potential benefit of protons. And I'm not saying proton can benefit all the patients, but in a select group of patients, they may benefit from proton beam therapy. This is a small randomized study from MD Anderson. They randomized patients between proton versus photon, all treated with conventional fractionations. And in this study, proton clearly show clear dosimetric benefit to almost all structures that they evaluated. They didn't see any difference in the overall survival difference, but they do show that proton can lower some of the low-grade fatigue, as well as reducing the high-grade lymphopenia risk. And these high-grade lymphopenia is likely associated to the low-dose radiation dose that received in the brain. And the larger the brain tissue receive the dose, the more risk having the lymphopenia. And the strong predictor are the female lymphocyte count and the whole brain volumes. So for selected patients, for example, the patient already have very low lymphocyte count, or the tumor is very big, which we expect large brain volume will be radiated, maybe proton can benefit in these kinds of subset of patients. So back to our case one. So this guy has a IDH wild-type glioblastoma, total resections, and then this is a 1 month post-op, and then we did the radiation, and then this is 1 month after the radiation. The patient did 59.4 gray in 33 fractions, and on this view, this picture here, this is a proton plan, and you can see my beam coming from the back and the side and the vertex beams. And then this is a comparison VMAT plan that the insurance requires us to compare. And you can see that proton clearly, this is a 20% isodose line, the orange, and the white line is the 50% isodose line. And the high dose line, although is very similar, but proton clearly can reduce the low to intermediate dose surrounding the normal brain area that doesn't need the radiation. So the patient did pretty well after radiation. He went on to receive adjuvant temozolomide and had a tumor treating field, and it was doing well at the last follow-up. So to take a little bit look at the tumor treating field, TT field is a portable device that generates alternating electric fields using a transducer array. So the patient has 4 arrays, 2 from the front and back, and 2 from the sides, and kind of sandwiching the tumor or the volume between the arrays. And the array will be connecting to a battery pack, which I took a picture here. And then they'll be turned on, they'll be start after the radiation. And the goal is to use it on average 18 hours, more than 18 hours a day, in an average of 30-day period of time. And ideally use it up to 2 years according to the protocols. And the EF14 studies, which published a couple of years ago, that show that improving survival from 16 months to 21 months using the TT fields after the radiation. These the side effects are pretty minimum and generally some local skin issues. And the prospective study didn't show any increased seizure or detrimental effect on the quality of life. And this is one of our patients treated at our center, and he did pretty well, and then actually did a video for the ASTRO patient education information video. So this is right here. So moving on to case 2, and so this is a 78-year-old man, had a seizure, and then had some confusion, had some left side weakness. And at that time, the MRI showed a mass in the right temporal region. He had a surgery, and then pathology confirmed glioblastoma. This is again, I somehow choose another methylated tumor, and the patient had this is radiation plan and target volume almost 60 gray with concurrent Timodar. So right after radiation, this is immediate, about 4 weeks after radiation, we have an MRI. And it actually looks a little bit worse comparing to the pre-radiation imaging, but the patient is not symptomatic at that time. About 2 months after the radiation, the patient was presented to the emergency room for generalized weakness, some confusion. They did another MRI. They diagnosed with dehydration, giving some fluids, and actually giving steroid at the time. The patient got better. Because the patient responded to the steroid, the medical oncologist feel that this may be radiation necrosis, and then empirically treated with Avastin for 5 milligrams per kilogram IV every 2 weeks for 4 cycles. And so about a month after the bevacizumab, the skin actually looks further improvement, and then they continue to improve 10 months after the Avastin. And so we feel that this is probably a radiation necrosis effect. And the patients do pretty well. Last about 18 months, no evidence disease. So common toxicity and side effect from the radiation. During the radiation, you may notice some fatigue and tiredness, some headaches from the swelling, some nausea. There will be also some hair loss. And if the patient initially presents with seizure, we'll also need to check for seizure activities. And after the radiation, most people recover pretty well. But long-term wise, we do need to mainly monitor the radiation necrosis. This is the information trying to looking at the risk of damaging to the organs. That mainly if we can keep the dose under the constraint, the risk of having complications is relatively low. Other structures that didn't include in contact studies, but we like to keep it as low is including pituitary gland and hypothalamus, as well as the hippocampus. For the radiation necrosis wise, as our patient demonstrated, usually it's a hyperinflammation at the margin of the parenchyma, but not the inside itself, and usually from damaged endothelial cells. And some of the advanced brain tumor imaging may be helpful, including perfusion scans, spectroscopies, or the specialized PET-CT with different tracers. Usually, biopsy is needed. It is confirmatory, but it's not absolutely needed because we often treat it empirically. And the first often treatment is the corticosteroid if the patient is symptomatic. If this is refractory steroids, we can often consider Avastin, or we'll call bevacizumab. And there's a very small randomized study published many years ago that looking at the Bev treated with radiation necrosis, they show all the patients, even though there's only like I think like 10 or 14 14 patients, they all shows improvement of the both radiographic and neurologic improvement after the Avastin. So in addition to Avastin, some people the interstitial thermal ablation is also quite successful, and also the patient need to go resection if still refractory. So moving on to case 3. So this is a 71-year-old man. Previously, he's a restaurant owner, like managing the accountings and the numbers, and then do a lot of work. But over the past few weeks, the patient's family noticed that he has worsening speech, and then also have some cognitive decline. And then they eventually got an MRI, show the enhancing lesion right here. So he was saw by a neurosurgeon and underwent surgery. And pathology did confirm glioblastoma IDH wild type. Unfortunately, he did have some infection after the surgery and required washout and antibiotics for a couple of weeks. He then went to another facility, tertiary academic center, for a second opinion, but then eventually referred back to us to do the radiation. And then when we do the planning, we do the MRI. This is about 3 months after surgery. The tumor already relapsed. So for the questions for the audience, so this is a 71-year-old man, had a near complete resection initially, had some complications, recover, not fully recover, performance status still kind of getting better, but not back to baseline. And what would be your radiation treatment regimen? Again, there's no absolutely right or wrong on these. So just to want to see what everyone thinks. So the first one is, of course, full course conventional fractionation. Second one is moderate hypofractionation. And third one is also moderate hypofractionation. And the fourth one is, of course, a very short course. Hopefully, I'm not going too fast. Is that okay?
No, it's good. It's good. So we have 87% of people answering. So I'm ending the poll, sharing results.
Okay. So most seems like 60%. Most people still choose the full course, about 6 weeks of radiation. About a third choose the 3 weeks radiation. Some choose the 2 weeks, and then I don't see anyone choose the 1 week radiation here. Okay.
So what would you do?
So that's so I'll talk about what I do. But
Yeah.
I start with some backgrounds. So this patient, so there's multiple studies trying to see for the slightly older patients, maybe borderline performance status. So is there a benefit to do full course versus a shorter course radiation? So from the Canadian groups, that they have a randomized study comparing for the glioblastoma, a little bit older, borderline or to higher performance status. They randomized between the full course radiation versus the 40 gray and 15 fractions. And these patients, of course, they didn't get chemotherapy, and they showed that they have similar survival about 6 months, 5 to 6 months after the radiation. And but the caveat is this is a small trial, only 100 patients, and a lot of patients died very soon afterwards, didn't really able to complete a quality of life assessment. But we know that 40 gray and 15 fraction is pretty safe from the studies. And then that brought to the randomized study with these glioblastoma larger studies with this short course radiation plus or minus temozolomide. And their target volume is the CTV plus 1.5 centimeter, just from the enhancement areas. And they show that adding temozolomide to this hypofractionation course can improve the overall survivals. And it's safe and able to use. So I would say if you do the 3 weeks radiation, adding temozolomide can actually have a little bit better outcome. But keep in mind that these patients still only live for around 9 months, right? Comparing to the STOOP study that and with the tumor treating field, they can live up to like 22, median survival is like 21 months, right? So for these patients, the baseline is already have a little bit unfavorable baseline. So for my case, it's interesting because when I saw the patient, I know I want to do a shorter course. So I initially offered a 3 weeks radiation. So I did a 40 gray in 15 fraction regimen using the VMAP lens. And this is, you can see it here. The tumor volume is pretty big, but we generally he did very good with, because he wanted to get treatment and he did got concurrent temozolomide. But he did so well, and over the course of treatment, he keep getting better. And at the end of the treatment, he said, "Well, I know I may not be able to cure it, but is there anything that you can do to make sure the tumor is even controlled better?" So I thought about it. I did give this a little bit boost to the growth disease. I did a re-CTs and then boost the growth disease just a 5 millimeter area using protons to a little bit higher dose to total of like 55 gray, but biologically probably around 60 gray-ish. And because we use the proton, we can keep the brainstem and the optic structure essentially the same dose without getting additional dose from the boost area. So I feel it's pretty safe, just boosting the tumor. And the patient did continue temozolomide after the radiation. We talked about the tumor treating field, but the patient didn't want to do it. He did live for about 6 months after the radiation, and then transitioned to hospice afterwards. So I don't know if boost helps, but at least we know, at least with a proton, we can do it safely in this case. So case 4, this is 81-year-old female. Even though 81, she previously lived pretty independent by herself. But over the past few weeks, she has some cognitive changes. She has generalized weakness. She has fell a couple of times. She has worsening headaches, and then went to the emergency room and found to be in hypertensive urgencies. And then they did a head CT, making sure she didn't have a stroke, and then showed that there's some mass in the left occipital area. That prompted the MRI, which showed multiple enhancing lesions in different parts of the brain, mostly on the left side. So that looks concerning. And then the neurosurgeon did offer her a left occipital craniotomy and more of an aggressive debulking surgery, and confirmed the pathology as glioblastoma IDH wild type. And post-op wise, she has some word finding difficulties, and then still have some confusions. She was sent to rehab for physical therapy. And 1 month after the surgery, we were able to see her for an MRI, and there all these show there's a new spot that showed up in different parts of the brain, and some spot actually got bigger. So in this case, we talked about even shorter course. So I think her prognosis is not very good. So there's courses or regimen we can do even shorter course. From the Nordic older GBM studies, they're looking at patients not doing very well, didn't have a good performance status, older patients, and then they do the radiation alone, conventional fractionation versus 34 gray in 10 fractions versus just temozolomide alone. And interestingly, they didn't show any survival difference, but they did show that the compliance rate, the temozolomide alone, only about a third of patients able to be compliant with the temozolomide. The short course, 10 fraction course, actually compliance rate is really high, and also a lot of the patients getting temozolomide alone actually get a second line therapy, including radiations. So, but they didn't really assess the PFS. but they did show that this regimen is relatively safe. And in Canada, they did looking at shorter course radiation for these frail patients, older patients, and comparing the 40 gray and 15 fraction versus 5 gray times 5 fractions. And then they show that there's no difference in overall survival. But again, this is, I think the criticism of this study is that this probably may be an underpowered study for non-inferiority, but this shows that this is relatively safe to do. So for my case, I did offer her 5 gray times 5. You can see the volume is pretty big, but I did use VMAT, and the dose is relatively tolerable. The patient did pretty well afterwards. I generally keep the optic structure less than 25 gray and brainstem less than 23, and then the cochlea low if we can. So case 5, moving on, this is a young lady, 42 years old. She runs marathon and multiple times. And then she very healthy, but she was working and then found to have a headache. And then really was found unconscious on the floor, possibly had a seizure. And then she brought to the hospital and then showed that the MRI shows a mass in the right frontal area here. She was brought to the OR and underwent craniotomy and confirmed glioblastoma. And this is the imaging after the surgery, a good resection. So she was treated with post-op radiation with concurrent Timodar, 60 gray in 30 fractions. So she did pretty good after surgery, after radiation. And 3 months, 6 months, and 10 months after surgery, the cavity continued to regress, and even 10 months looks very good. But about a year after the radiation, she then had seizure, and she didn't have seizure throughout the whole year, but then the seizure came back. She brought her back to hospital, had the MRI, and then this is what it shows. Like this is kind of look like recurrence. So question for the group. So 42-year-old had a full course 60 gray radiation with Timodar a year ago, and now with suspicious recurrence. So she did surgery, and let's assume that the recurrence is confirmed. What would be your recommendation after the surgery? And we thought about one observation. Second is resume temozolomide alone, and you can add any other systemic therapy if you want to. The medon can add different kind of lomustine or other systemic therapy. The third option is to adjuvant radiation, and fourth option is tumor treating field. Again, these are no right and wrong answer. Most of them are reasonable, so just want to hear what everyone has in mind. And I also understand that depends on your the resources that different places have, and the reason to offer one versus the other depends on the specialties and the things that the resources that each facility has.
Okay, so we have 89% answering. So I'm ending the poll, sharing results.
Yeah, so it seems like about half of the group feels that we will offer adjuvant radiation. A third will resume systemic therapy, and then 10% the TT field treatment, and then some just watch it. Okay. All right. So of course, when the glioblastoma recurs, this is not very good. And generally, I think about the things that I will consider first when we're thinking about treatment options. First is what's the goal of the treatment, right? Are we still trying to cure the patient, or just trying to palliate the symptoms, right? And that also depends on the prognosis, because if it has a good prognosis, we want to be aggressive, then we may want to that may affect our treatment options or selections. But when the prognosis is not very good, then we may the goal may be not trying to not to hurt the patient, right? And oftentimes the performance status is the most important criteria determining the prognosis of the patient. And I also want to look for the biology of the tumor, including the molecular subtypes and some of the target therapies. And here just listed some of the potential options. Of course, none of them are absolutely yes or no. So I do need to think about resectability, right? And whether this is an area is able to be resected, how was the patient's condition undergoing a second surgery, and how aggressive we want it to be, right? And then what are our systemic therapy options? Because this is a talk from a radiation oncologist, so we kind of need to promote. I want to promote radiation for treating these patients. And this is a secondary analysis from the RTOG 0525. These patients, they're looking at the patients that progress after initial therapy, and then see what are the treatment options the patient gets. And clearly, radiation, treating radiation with or without systemic therapy, in this case Avastin, do better than not doing anything, right? So we know treating improving the survival. So having the right patient that we think that has a reasonable prognosis, providing additional treatment is worthwhile. And different treatment options exist in the radiation world. I understand that there's some other therapy option, including brachytherapy, intraoperative brachytherapy, intraoperative CCNU wafer, or even oncolytic viruses. But these three are kind of need to be specialized, may not be very available. But external beam radiation, most places we can offer, right? So external beam radiation-wise, there's a couple of different options. You can treat it by itself, or treat it as the RTOG 1205, or treat it as the EORTC Legato study, which is lomustine with or without radiation. So I just want to talk about the RTOG 1205 study, which is about 180 patients with recurrent glioblastoma, had prior radiation more than 6 months ago. They do limit the total tumor volume less than 6 centimeter. The patient needs to have decent performance status, and then randomized between bevacizumab with or without radiation, right? And the dose they give is 35 gray in 10 fractions. They do kind of limiting the treatment volume, only getting the cavity with maximum of 5 millimeter CTV extensions. And they are very careful that not making sure the dose doesn't exceed the optics and the brainstems. And this is quite safe to do. And they did show that the adding radiation with the bevacizumab able to improve the median progression-free survival from 3.8 months to almost 7.1 months. And the response rate can also be improved as well. So I do think with this data, it's quite, if we're going to do the Avastin, adding radiation, external beam radiation, is quite reasonable to do. And here are some other studies using bevacizumab with other type of radiation, just the table right here. And they generally see that the median survival after the recurrence, about 9 to 10 months after the recurrence for a reasonable prognosis patient. So for my patients, the patient actually underwent the repeat craniotomy, and you can see she had a good resection after the surgery. Unfortunately, even after a couple of weeks after the surgery, I brought her back to do planning for post-op radiation. We did an MRI, and this showed that this looks like recurrence to me, and showed early relapse. So we go ahead and start the Avastin and the salvage radiation. I did the 35 gray in 10 fractions. I used the proton beam therapy, and you can see that the proton beam has a very good DVH, very minimum dose to the other brain tissues, essentially no dose to the other organ at risk. And then this is a radiation plan. And about 3-4 months after the radiation, we did a MRI, and she has a very good response, right? All these enhancements all pretty much went away, and her functional status is really good. I saw her about 6 to 8 months after the radiation, still no recurrence. But unfortunately, she did have about 9 months afterwards, she did have a lung infection and has complication from the lung infection. But at the time, at least the brain is still under control. So, okay, I think we have a little bit of time to go over the last case. Just go over quickly. This is a 67-year-old man, has glioblastoma, IDH wild type, treated at the other institution about a year ago. They give him 40 gray and 15 fractions at the time. From his surveillance MRI, they show that there's a gradually increasing enhancement right at the superior part of the resection cavity, suspicious for progression. So when he was referred to me initially for proton radiation because it's a recurrence. But when I saw the lesion, I did talk to him about doing surgery or other focal treatments. The patient refused surgery, but the lesion got bigger. And then I offer him to do the radiosurgery just to this enhancing area. So I give him about 25 gray in 1 fraction, limited to the enhancing area. And on the subsequent scan, actually, you can see the enhancement actually went away. And he did okay for a couple months, but about 6 months later, he developed like a kind of diffuse enhancement along these areas. And then he also have like neurologically declined. And we started the steroid, it didn't really help. And then we talked about biopsy. The patient didn't want to do it. So we had spectroscopy scan shows like kind of suspicious recurrence. So we offer salvage treatment. In this case, I did give 25 gray and 5 fractions. The patient did okay for almost 6 months, but then passed away later. So that's another option to do the kind of the radiosurgery as an option, but I mean, these are not curable cases, right? So to summarize, right now, as of 2024, I have some summary how I treat the glioblastoma for young patients, good performance status, surgery, conventional fractionation with concurrent temozolomide, or temozolomide with CCNU. I generally offer the tumor TT field treatments. And for older patients, treatment can be slightly hypofractionated. If the patient can undergo concurrent chemo, I would do the moderate hypofractionation. If a patient is frail, not able to do the chemo, then we can do the shorter course, either 2 weeks or 1 week radiation. Sometimes doing temozolomide alone may be reasonable. Recurrent disease all depends on what the situation is. And I know we have a couple cases that we want to discuss on the recurrent setting later today, right?
Thank you. That was a great summary. Thank you so much. Dr. Silaieva, do you want to share?
Oh, sorry. Good evening, dear colleagues. Thank you for opportunity to present the cases of glioblastoma treatment, and I think these cases will deserve attention. Following questions about re-radiation and difficult localizations for radiotherapy planning. Okay. So the first case, it's a 68-year-old male patient with glioblastoma. Firstly, the tumor partially removed after ventriculostomy in 2018. The patient underwent a standard course of radiation therapy to the tumor bed and residual tumor up to 60 grays in 30 fractions with concurrent chemotherapy temozolomide. We used in 1918 expansion to GTV 2 centimeters. Unfortunately, the plan from previous course of treatment is not available, but after the first radiation therapy, he received 12 cycles of adjuvant chemotherapy with temozolomide. After 1.5 years, the patient was diagnosed with melanoma of the anterior chest wall. He had surgery, and after surgery, prescribed by oncologist 6 cycles of chemo. After 5 years of remission, the patient was detected with multifocal brain lesions, which is typical for glioblastoma recurrence. In this case, the surgery is not possible due to localization. It was decided to undergo a re-radiation course, taking into account the long break without any progression. Due to the large volume, stereotactic radiosurgery is not possible, and we planned 35 grays in 10 fractions with concurrent temozolomide chemotherapy. The margin from GTV to CTV was 5 centimeters. Oh, sorry, 5 millimeters. And the margin from CTV to PTV was 3 millimeters. As we can see on the other side, the difficult planning was proximity to the optic tracts, brainstem invasion, and thalamic invasion. As you can see on this plan, the planning was performed using the repair technique with the limitation of high doses to the brainstem and optical structures. We made the decision to cover GTV in brainstem with a lower dose to avoid acute effects, considering that systemic therapy plays an important role in improving survival in glioblastoma recurrence. And directly dose volume histogram, we can see that the dose volume histogram looks atypical due to the need to reduce dose to critical structures. And our question to the first case. How would you treat this patient and manage dose distribution? About toxicity management, how to reduce toxicity in case of re-radiation. About re-radiation, what is your attitude to re-radiation in this case? And which recommendations can you give on dose and content of re-radiation of glioblastoma?
Yeah, thank you for that case. So recurrent glioblastoma is always very challenging, right? Because typically they already receive a full dose radiation then, and the location is always often challenging. But this is actually quite interesting. This patient had a glioblastoma 5 years ago, right? And then I mean, late recurrence is not very common. So that's quite interesting to about this. This is a different biology there. So I actually, when I'm looking at the case, again, when I reviewing it, we're thinking about, okay, the extent of disease, we talk about the goal of the treatment, we talk about the, and then the resectability, all these things. There's actually I agree that this is not a resectable case, but I do think that there's also a German, looking at the prognosis, you can also do a German re-radiation risk scores that's been published a couple of years ago that kind of assessing the overall survival to assess the prognosis. But looking at this tumor per se, I would be interesting to see that whether you would be at least do a biopsy of this tumor, given that the patient had a history of melanoma, and also this tumor at the tectum area. Even though most of the tectum tumor are lower grade disease, sometimes the tectum tumor can have some like a molecular mutations, like BRAF mutations or something, that if there's a target mutation that can be offered to the patient, that may be something to consider. I think treating the patient with radiation is quite reasonable. I will offer radiation. The 35 gray in 10 fractions is very safe, I think, like that we know. So I have no problem of giving 35 gray in 10 fractions, even if we don't know the prior radiation plan. And sometimes with the dose very close to the brainstem, we can even do the more like the conventional fractionation, 36 to 40 gray in 18 or 20 fractions. That generally are pretty safe too, as long as I try to keep the cumulative dose less than 100 gray for the brains, and then maybe 90 to 95 gray for the brainstems. The how much dose can accumulate for the radiation in the brain is really, no one really knows, right? But generally we feel that less than 100 gray is reasonably safe. If you extrapolate it from the spine studies, that more than a year later, the dose would, people, they should recover from the radiation. Maybe they can even be safe to do 100 grays. I will also watch for the dose, the optics. The optic structures, I generally keep it less than 80 gray total accumulated dose. I feel that re-irradiation should consider proton, because we can really reducing the radiation dose to the surrounding areas. You see my comparison point between photon and proton, even the 20 to 50% isodose line can be reduced by the radiation, by the proton radiation. So that may be something to consider. So yeah, so as to reducing the volume, I think you need to be as tight as possible, right? So you have an MRI really to curve back the structures that doesn't involving the tumor. And also, I would also add a PRV for the organ at risk to making sure the dose doesn't exceed those areas. Yeah, so reducing the risk. The other thing I would also think about is to the benefit of adding Avastin is that for the patient, if the patient does develop radiation necrosis, the Avastin can reduce that, right? So I think that's also why Avastin works pretty well with the radiation settings, that because they also reduce the necrosis risk.
In case of this patient, I didn't say, but performance status was poor also, because their localization of the tumor was in brainstem, thalamus. Okay, thank you. Sorry, next case. So, patient 61 years old, man with glioblastoma, IDH wild type, left temporal medial region. He suffers from epilepsy. In 1992, a partial removal of tumor was performed, followed by a course of radiotherapy with concurrent temozolomide. It was planned to deliver 60 grays in 30 fraction, but the patient declined the last session of radiotherapy. This slide shows the contouring. We can see that tumor invades the brainstem and is in contact with optic tract. We didn't crop CTV from the brainstem, taking into account the invasion. the margin from GTV to CTV was 15 millimeters, and the margin from CTV to PTV 3 millimeters. And the plan with dose distribution, we can see different dose levels due to rapid arc modulation, which allows us to limit the dose to critical structures. And also dose volume histogram. We also save the critical structures like brainstem and optic ducts. And on this slide, we can see MRI monitoring in the dynamic. Patient received 6 courses of temozolomide and 9 intravenous injection of bevacizumab. In dynamic service MRI, we see the excellent result in decreasing tumor mass after radiotherapy, chemotherapy, and antiangiogenic therapy. But after 17 months, with stable pictures in the brain, he received progression of the disease in the spinal cord at the level of second, third thoracic vertebrae, which according to the MRI is more typical for the satellite of glioblastoma. Neurosurgeons declined the patient from surgery and biopsy due to poor performance status. This slide shows the contouring of intra-extramedullary spinal cord tumor. You can see that the PTV was 1 centimeter. This was taken into account given the patient's lack of mobility and possible displacement during the treatment. The treatment plan was chosen as palliative, taking into account the patient condition. And the desire of patients relative to use all possibilities treatment options. Dose distribution is present and also dose volume histogram. This dose volume histogram was excellent in PTV, GTV, and CTV also. And our questions about second case. How would you treat this patient? Management of dose distribution. How often do you see glioblastoma metastasis to the spinal cord in your practice? And what is treatment strategy? Maybe some further recommendations for patient management, palliative and supportive care.
Oh, so I think I remember when I was in training, we heard about these metastases of glioblastoma. I was always told it was rare, but then as I start being practice on my own, at least at first I didn't see anything, but then as the years go by, I do start seeing some patients, and then we're looking into the literature. It actually shows that it's not common, but it's actually higher than what I initially thought. And it's actually really interesting to look at the initial pathology to see what kind of glioblastoma the patient has, because there's actually a subtype of glioblastoma that the primitive neuroendocrine neuronal subtype actually has a high tendency to spread to the spinal cord, spinal canals. And and there's also a autopsy studies that looking at all the glioblastoma patients. It's a small series, but they show that there's like a 10% of people that do have spreading to the spinal cord, but they just died already because of the primary site also progressed. anyhow, but this patient, you mentioned that she is not a good performance status patient, right?
Her performance status was poor.
Yeah, so I think that kind of determine what we need to do, because I initially I thought, okay, if it's not the good performance status, the prognosis is poor, then the goal of treatment is really palliative, right? So then palliation, 30 gray in 10 fractions or 35 in 10 is quite reasonable. But just for the discussion's sake, if this is a good performance status patient, more than a year out from the primary site treatment, while the primary site is still controlled, I mean, generally, I think we can think about, if we want to treat it aggressively, what are the things we need to consider, right? So I would say first, we should at least do a full workup, making sure that making sure that primary site in the brain is controlled. You probably need to get a full spine MRI, making sure there's no other gross disease. I will also add like a CSF analysis, making sure there's no other drop metastasis, or there's only the site of disease or not. Because if it's a good prognosis, then aggressive therapy is warranted. We really need to assess the extent of disease. And then if it's truly localized, then I think we need to set about the resectability, right? This tumor is really intramedullary, so it's not really resectable. But it may be worthwhile to talk to the radiologist, I mean, not radiologist, neurosurgeons, to get a biopsy, because it could be a second type of tumor, right? It could be a primary spinal cord tumor, not a glioblastoma met, if that's the localized disease. And then we can think about how aggressively we want to treat. For really localized disease, trying to treat definitively in the spine, I think we can think about giving the dose higher, right? 45 to 50 gray is quite safe to the spinal cord. And if you want to push it higher to 54 gray, the contact study only showed a 1% of necrosis rate in the spine, right? So if it's really localized, good performance status, won't be aggressive, then be treating to 50 gray a little bit higher may not be unreasonable. Hypofractionation wise, for defensive cases, I do 40 gray and 15 fractions, and then keep the spinal cord less than 42 gray. But then if you do conventional fractionation to 45 to 50 gray, it's quite safe to do. As for volume wise, I think your volume is great. It's good. I generally do gross disease plus two vertebral body above and below the gross volumes. So that probably that's about 2 to 3 centimeter. So very similar to your volume. I do kind of limit it to the canal and the neuroforamen. The CTV, I don't go into the bone that much, but the PTV, of course, you will add to that PTV margin to including the bones. The other thing is that if you do have in some cases, we do a full spinal radiation. If the volume is that big, then you can consider doing proton to really reducing the side effects for the acute, like nausea and kind of side effects. But those are for different cases. For a patient with kind of borderline performance status already, doesn't have a very good prognosis, you just want to palliate the case, like 35 gray in 10 fractions is quite reasonable to do. Yeah.
Thank you.
Sounds good. Thank you so much, Dr. Silaieva. I see a lot of questions in the chat. So one question is, Dr. Wang, thank you for a great talk. Can we ask, do you use MR-DTI tractography for your contouring for white matter spread glioblastoma evaluation?
Yeah, that's a good question. Yes, that's an area that kind of actively doing evaluation right now. I do think that tractography is a very good tool. It kind of I don't how do I say it? I still use it at least at 1.5 centimeter, but I do looking at the tractography and then see there's additional margin I need to expand, right? So sometimes I see the tumor expanding to that direction. I may if I'm more about it, I try to use the tractography to kind of extend it a little bit more. But right now I try not to reduce the margin too much out of the 1.5 centimeter, because there are times that I'm pretty sure everyone has the experience. I did a 1.5 centimeter margin and tumor fell right between 1.5 to 2 centimeter area, right? So and that happens, and that happens for the glioblastoma cases. Yeah.
Thank you. Another question is from Dr. Sokolovska. Dr. Wang, thank you for excellent lecture. If we observe multiple lesions of glioblastoma in 2 lobes, and we understand that the treatment volume would be big, do we need to decrease CTV margin, or what decision can we make in this case?
So you're asking multifocal disease,
Right,
right? So
multifocal.
yeah, so multifocal glioblastoma is actually more common, right? So we probably see like 10% at least the multifocal disease glioblastomas. So what I do is I do contour both targets separately, and then I do add at least 1.5 centimeter margin for each tumors. And I do try to see if they're connecting with each other. I don't reduce the margin too much, but I understand the margin is that the volume will be quite big. I have one case that has basically from the one side from the tumor on the right parietal area at the back of the ventricle, and then the other at the right frontal, right? So then we add the margin pretty much connecting the whole sides. In those cases, I generally don't do the RTOG volumes, the 2 centimeter ones, but I do still use the ERTC 1.5 centimeter margin. Yeah.
Okay. In the case of hemorrhage in the tumor bed during RT, is the absolute contraindication to continue treatment, or what do we have to do with the patient in this case? Hemorrhage during RT.
Well, depends on the symptomatic or not. Not glioblastoma. I just recently had a case that it's a brain metastasis case that had I think it was from melanoma metastasis to the brain, and he had a resection, and then I was going to do the cavity radiation, right? So I saw him about 3 weeks out from the surgery, and then we have an MRI, and then the 2 days later I did a CT stimulation, and because we had Linac base, and then just between that a day and a half to 2 days time, the cavity, there's a bleeding in the cavity, right? So then like everything changed. So I actually abort our plan and then redo getting a new MRI, did a new plan. I still treat it, but I do reducing the dose, but I treat the whole cavity with a radiosurgery dose. But I don't think it's an absolute contraindication. But I do think need to see how the patient is doing, right? Sometimes my patient wasn't symptomatic, so I went ahead and do the treatment. But if the patient is symptomatic and the cavity the hemorrhage getting bigger and bigger, then the surgeon actually need to go in to stop the bleeding, right? So I think it depends on the case, yeah. And that's definitely not a good prognosis for the patient, and because that interrupting the radiation, if he need to undergo surgery to stop the bleeding, that may change your volume, that may affect a lot. And so yeah, it's not the absolute contraindication, but it really depends on how much it has changed your tumor volume. And because we do cone beam CTs every day for our patient, even on the protons, so we can kind of see the changes. If you notice the volume is changing outside your target, you definitely need to stop the treatment and figuring out whether it's stabilized, replan it, or the patient need to go surgery, etc. So it depends on the situation. Yeah.
Thank you. There's another question from Dr. Pali. Thank you for the interesting cases. Question for Dr. Silaieva. What equipment do you use, and how often do you use table rotation in treatment of glioblastoma?
For the brain tumors treatment, we use TrueBeam. And also with table rotation, when it all depends on the tumor location. In this way, we can ensure better dose distribution and preservation of critical structures, especially if we are talking about young patients.
Okay.
So for like IMRT plan or VMAT plan, I mean VMAT, we do VMAT a lot in our center for the photon plans, and usually 2 arcs is pretty good. For some of the IMRT plan, we do adding a vertex beam that can help the dose distribution. Proton wise, we generally have 3 plans, three beams, and usually a lateral beam, posterior, and maybe a vertex beam, depends on the tumor locations. So those that vertex ones does need to rotate the couch. Yeah.
We also use VMAT rapid arc planning, and when we use couch rotation, we use some part of arc.
Partial arcs, yeah. Yeah, sounds good. So we call them sagittal arcs that go a little bit angled. Great. I would like to open questions to audience. If someone wants to turn on the microphone and ask a question, please go ahead. So there are lots of things in the chat. Thank you.
So I was looking at the chat. Someone's asking. I think you already answered. Proton CTV. Yes, proton planning do require CTV, but with the robustness planning, we don't have PTV. But yeah, they still use CTV to plan.
Yeah, excellent. So if nobody is asking questions, I'll ask a question. Dr. Sokolowska, go ahead.
Yeah, I'm sorry for interrupting you, Dr. Wang. Thank you again for the great lecture. And I have a question about dexamethasone or biosteroids. What doses have you used during the treatment and how long? Probably maybe for the first time, and after that you stop to give it.
Yeah, so if the patient is symptomatic requiring the dexamethasone, I generally do a 4 milligram 3 times a day for if the patient is symptomatic. But I try to monitor how the patient is doing, right? If the patient is doing well, I start tapering down to 2 times a day very quickly, and then once a day, and see how the patient do. I taper it down if the patient responds after 3-4 days, I start decreasing it already. I do tend to stay on the once a day for 4 milligram once a day for a little bit while for at least 1 to 2 weeks to see how the patient is doing and determine how much we can further taper. So hopefully, I mean, yeah, so it all depends on the patient situation, but 4 milligram outpatient setting, 4 milligram 3 times a day is pretty good. I found it a little bit challenging for patient doing Q6 hours as the outpatient setting. If the patient is inpatient, of course, there's no problem. Do 4 milligram Q6 is quite easy to do. Yeah.
Thank you very much.
Thank you. I wanted to ask a question, Dr. Wang. We are really not doing so well controlling glioblastoma and curing the disease, right? So we're doing quite poorly. I would say we are failing. We may be extending life by a little bit, not much. And I was wondering, what's the hope there? What can we do to improve? Maybe CAR T cell therapy. Currently, it's only available for recurrent patient, right? Nothing for primary disease. So I'm just wondering, like, what are you maybe hopeful for the future? How can we do better?
I think biology is really important, right? I mean, I think I feel like glioblastoma every 10 years there's some advances, right? So from the initially surgery and then adding radiation, adding Temodar, adding TT field treatment, about every 10 years or so you have some improvement.
Breakthrough.
Yeah, breakthroughs, and then the overall survival from 0% to 5 to 10%, and these days for generally about if you're looking at the EF14 studies, about 10 to 15% long-term overall survivals, right, for survivors. and we do see that, I do see that every year we have a couple patients that live more than 2 years and then disease-free for a long time, right? For my short career so far, yeah.
Right,
But
right.
so I do think we're curing some patients, but I think a lot of it depends on the biology. If the right biology, we can cure the patient. But there's still a lot of the patients that these biology is just resistant to radiation, resistant to the chemo. So finding the right biology, treating the patient correctly, that's the most important next step. And whether we can further advance by combining the different technology to different kind of tumors, that's also important too, right? So no matter it's combining radiation to other new drugs or monitoring or have better imaging studies, like someone asking about the tractoscopy
Right, right.
or advanced, there's some other advanced PET scans like the DOPA PET and the other kind of metabolite PETs that can really help defining the tumor even better or detecting the tumor earlier. That may be something to further improve the outcomes. I don't, yes, you're right, we may not be able to cure everyone, but I think seeing the progress in glioblastoma for the past 40 years, every 10 years or so, because of people like you guys working so hard in the academics, then you see a little bit more improvement. So I wouldn't be too pessimistic. I still have hope in this field.
That's great. And are there any exciting studies that you are waiting for? Any NRG studies?
So
Biomarker studies?
I need to probably review it at the ASTRO this year. Yeah.
Sounds good.
I mean, we try so hard different things, right? So we try to
Right,
dose escalation studies. We
right.
try the immunotherapies in upfront settings, but that's what happens for these glioblastomas. It's like we struggle for 10 years and then we have some breakthroughs, right? So I'm looking forward every year to see if we have new breakthroughs. Yeah.
That's great. Dr. Silaieva, what are you hopeful for glioblastoma patients? How can we find the cure?
Maybe in some times we see the vaccines which will be with good results and we can use it in widely, not only in Germany, USA, but in Ukraine also.
Yeah, definitely. I know that tumor treating fields are not used in Ukraine. Is that correct?
No.
Well, what do you think, Dr. Wang, about the tumor treating fields? There's marginal benefit, right? And
Yeah,
it decreases the quality of life.
that's
So,
quite interesting because
yeah.
if you're looking at the benefit of tumor treating field provides, it's like 4 or 5 months from the control arm, right? And if you're looking at the temozolomide benefit, that's also extending 4 or 5 months, right? So yeah, on the medium survival, but because of all these treatments, we have more patients live more than 2 years, like live more than 2 years out, right? So I think I offer it to my patients. So we're lucky in the US that we have it approved in the US, able to offer to the patients. But I do think it's something that's quite interesting, and the basic science are good. They have from the in vitro studies to animal studies to the randomized studies, and they also start showing it in other cancer types, right? So
Right,
they're looking at the ovarian cancer, the pancreatic cancer, mesotheliomas, or
right.
even though the data is not as strong as the glioblastoma, but if it works in other cancer type settings, I do think that we really need to seriously think about whether this underlying mechanism should be valid, right? And I think those, who knows that, let's see what in the next couple of years, there's maybe other technology that showed up. But I think glioblastoma, I do offer my patients TT field treatments. Of course, there's some challenges, including wearing it for like 18 hours a day, including shave the head every 2-3 days. So it can be challenging for some people, but I tell my patient that usually what I see from my patient is the hardest is the first couple of weeks that when you first started and kind of figuring out how to incorporate to your life. But once you get used to it, it's actually not too bad, not too hard to do it. I have like a picture I showed he's been on lab for more than 2-3 years and then really not affecting his quality of life too much. If you look at prospective study, the quality of life really is not decreased because of the TT field treatments. Yeah.
Yeah, excellent. Thank you so much. Thank you, both of you, for such a great session. We learned a lot today. And next session will be on GI cancers in the months. Thank you, everyone.
Good luck, everyone, enjoying
Bye.
the lecture.
And we will meet on ASTRO then.
Yes.
Bye.
Bye-bye.
Bye.